Good morning or afternoon, depending on where you're located, and welcome to today's webinar, Plugging In to the Needs of Low-Income Patients, Technology-Based Engagement Strategies. I'm Carolina Gutiérrez, Program Associate at Blue Shield of California Foundation. Before we get started, I wanted to go through a few housekeeping items. To avoid background noise, all callers will be automatically muted throughout this webinar. If you would like to ask a question during the course of the presentation, please do so in the question window on your screen. We will do our best to address your questions at the end of this presentation. Also, just a reminder that today's presentation is being recorded and will be archived on the Foundation's website. Please tell your colleagues who are unable to attend so that they can still benefit from the presentation and discussion. Joining me today is a longtime partner of the Foundation, Veenu Aulakh, Executive Director of the Center for Care Innovations. We will also hear from Dr. Justin Wu, the Associate Medical Director at Ravenswood Family Health Center, and Dr. Jeffrey Liang, Ambulatory Medical Director and Chief of Family Medicine for the Riverside County Health System. All three of these speakers bring tremendous knowledge and expertise to our discussion today, and we hope that their insights will help all of us working to advance patient engagement strategies in California's safety net. As many of you know, today's webinar is just one of the Foundation's ongoing efforts to bring patient voices into the conversation about the future of our healthcare system. Since 2011, we have been listening to low-income patients, asking about their healthcare needs, experiences, and preferences through randomized statewide surveys of more than 1,000 residents. Over the past 4 years, findings from these surveys have consistently underscored the importance of patient-centered approaches in the safety net and illuminate the crucial connection between engagement and patient satisfaction and loyalty. This webinar is the third in a series that looks at key aspects of our survey findings, and today's topic, using mobile and web technologies to improve patient engagement strategies, is especially timely. As our healthcare system continues to transform, the opportunities for innovation are greater than ever before. With remarkable advancements in technology, clinics and health centers have more and growing options for communicating with their patients and improving the way that care is delivered. Even with the digital divide in internet access between lower and higher income populations, there is clear evidence that safety net patients are open to using mobile and web technologies in their care. Our research shows that only 23% of low-income patients currently communicate with their providers by email, and only 16% by text. However, among those who do, a full 87% report that they find it useful, including 53% who say it's very useful. Even among those who lack the connectivity or technology to text or email with their providers, more than 7 in 10 express an interest in doing so. Beyond email and text messaging, online, printed, or video-based decision aids are also considered valuable. Low-income patients who use an online patient portal offered by their care facility are 22% more likely to feel very informed about their health, and 92% find the portals useful. In addition to enhancing patient engagement, adopting technology-based strategies also has the potential to sharply reduce the satisfaction gap between low and higher income Californians when it comes to their health care. Getting health information online and via mobile is positively linked to stronger patient-provider relationships, more empowered patients, and better care experiences overall. We hope that the public and community providers will continue to leverage these tools to advance healthcare for low-income Californians. With that, I would like to turn it over to Veenu to talk about the Center for Care Innovations and their efforts to catalyze new ideas and solutions across the safety net. The Foundation has had the privilege to support CCI for nearly a decade now, and we've benefited tremendously from Veenu's leadership and experience along the way. Also, before I hand things over, just a quick reminder that if you have any questions, please type them in the question window at any time. We will do our best to answer them during the Q&A section at the end of the webinar. I am now pleased to introduce Veenu Aulakh.
Hi, thanks Carolina for the warm introduction. And as Carolina said, I'm Veenu Aulakh, the Executive Director for the Center for Care Innovations, and I'm excited to share what we've been doing in partnership with the Blue Shield of California Foundation and the work we've been doing in designing grant programs, especially to support the use of technology and advancing patient engagement. And also looking forward to hearing how some of our clinic partners have taken advantage of some of our program opportunities and the experiences of actually implementing these interventions in their settings. So I wanted to start by just telling you a little bit about the Center for Care Innovations. So CCI has been around since 1999, starting as a community clinics initiative, and rebranded about 3 years ago to become the Center for Care Innovation. At CCI, our mission is really focused on how do we transform care for underserved populations. And the way we do that is really by working with our safety net partners to support changes, so primarily community health centers and public hospitals. We're really focused in making sure that safety net systems make the changes they need in order to really survive and really thrive in the next 3 to 5 years and hopefully much longer. And the way we go about doing our work is we do a lot of work to both design and run programs around critical changes, similar to what this program has been really about, which is a combination of supporting patient engagement, leveraging technology, which we think is really important, and also preparing for value-based payment and really thinking about engaging patients in ways beyond the face-to-face visit. So these are we play a big role in designing and running programs. We also, as part of all our programs, and you'll hear more about that in the context of this initiative, is really to bring people together. We think that the best ideas come from the safety net and try and build an important peer learning community so that people can really get at the heart of the issues and help each other. We also believe that it's also important to bring in experts. Sometimes those, many times those experts are also from safety net systems, but sometimes we bring in folks and consultants from the field who have deep expertise. And then lastly, we believe that a re-granting component or a grant component is really helpful to clinics working on innovations and ideas that are outside of their traditional way of working, giving them the bandwidth to support the work they do, travel to meetings, and purchase any technology that they might need to. We also at CCI believe that our role in supporting these changes is threefold. We think that in order to transform care, there's a role that CCI can play in helping spark innovations by teaching human-centered design thinking in our Catalyst program, trying to inspire folks to make changes. We also think there's an important role in seeding innovation, similar to this, providing some bandwidth to take risks and try new ideas. And then most importantly, I think with much of our work is how do we really play an effective role in spreading those great ideas that work. And frankly, what we're talking about in this webinar around patient portals and the texting is in that context of things that we've shown and safety net systems have shown make a big impact in the work they do. So last year we started a program, what we call our Spreading Innovations program, and this is done in partnership with Blue Shield of California Foundation, who had really seeded a number of innovations that clinics had shown to be quite successful. Also, in building off the results of the Langer study that Carolina referenced and the shift to value-based payment, we believed and we heard from our clinic partners that the importance of how to leverage technology tools and new approaches to make teams more effective was essential to engaging patients. on critical issues from improving access to improving health outcomes for people with chronic conditions. And so this past year we launched our second program around spread, and we focused on 5 successful projects around co-visits, patient portals, phone visits, texting and video collaboration, and finding ways to take these interventions that really had some success in the safety net and spread them to new organizations who are able to take them up and implement them. So today you're going to hear a little bit more about the importance of patient portals when you hear from Dr. Justin Wu. And I think many of us believe that this is an essential tool for our patients to be able to more effectively engage with their care teams. From everything from how do you more effectively communicate by emailing your doctor and care team, scheduling appointments, labs. These are some of the functionalities that we've been helping to support and promote. And in this past year, we had 12 teams really working on this initiative, looking at critical things like how do you implement this technology and take advantage of what the EMR portal has that works well, and working with some of the challenges of the portals that exist. How do we more effectively market and enroll patients, which has been, I think, a bigger challenge than we had anticipated. Starting to think about how you train providers, integrate into workflow. These are all the types of issues that have been brought up in this program. But I think the teams have been really grappling and learning from each other and how to best manage them. Similarly, for our texting program, we also launched last year, and now are getting ready to spread. As Carolina pointed out, we have heard, and the data shows that patients do have cell phones, but we haven't been very successful historically in leveraging those to be able to communicate and reach out to patients. And we know that there's a lot of tasks and ways of communicating that could be more effectively done that way. So we supported 9 teams in a variety of case studies, really allowing the clinics to think about what worked most effectively. And you're going to hear a lot from about how this worked from Dr. Jeffrey Liang about the experience in Riverside. And you can see a number of the case studies. I think one of the most popular case studies was really around appointment reminders and how to use texting for that, and then moving to some more complex and ways of communicating around chronic conditions. So the programs that were set up with some funding support, and I think the biggest benefit, especially in the context of the portal program, was a site visit to mentor organizations to really learn from others like them. The program also included support with coaching calls, a variety of toolkits and resources, web resources, which I'll talk about in a second. And then we also believe that there's an important role an implementation coach can play in just keeping folks on target, helping troubleshoot problems, and then including also a program evaluation and learning community. So that's how we designed the program. I want to just pull out the mentor sites concept. We believe that probably, especially in these programs leveraging technology, that some of the most insightful comments and challenges were addressed from others who had already implemented this and had a couple years of experience. So for our patient portal program, we really leveraged the Shasta Community Health Center, who also was using NextGen for their portal, and were able to help teams. And for the Texting for Better Care initiative, we have been leveraging a combination of those peers, just because we hadn't had a lot of previous successful examples, but we'll be leveraging those models like what Jeff's doing in Riverside to help future teams. So these, I think, this aspect of the program, I think, has been a very successful approach. And then one last, just to, for those of you interested in this topic, on our website, careinnovations.org, we have a Texting for Better Care toolkit, which gets provides you a number of resources that may be helpful for you as you are going down this path. Things like how do you select a vendor, how do you deal with the issues of consent and privacy, is there some research that you can reference. So I would encourage you to check out some of the tools there. Also, if you scroll down to our programs and find the Spreading Innovations program, you'll also be able to see a number of web resources and templates and guides that might be helpful as well. So with that, I wanted to now just sort of pass the baton to Dr. Justin Wu, who has been a great partner of ours in a number of initiatives, and he'll share kind of the on-the-ground experience around implementing patient portals. Justin Wu is the Associate Medical Director in Family Medicine and Clinical Informatics Officer for the Ravenswood Family Health Center, which is a growing federally qualified health center in East Palo Alto, California. Their health center serves over 13,000 patients in San Mateo County and provides primary care, dental, prenatal, and integrated behavioral health to a predominantly Latino and Asian Pacific Islander community. So with that, I'll pass over to you, Dr. Wu.
Great, thanks for the introduction, Veenu, and hi everyone. It's wonderful to be here today with you all, and just to share about our experience in this great grant and collaborative. So as Veenu mentioned, we participated in the Patient Portal Virtual Collaborative Grant through CCI, and I'm just going to be talking, giving you some brief highlights on sort of our goals going into this project, some of the challenges that we faced, some of the results that we got, and lessons learned. So just as a brief background on where we were at as an organization when we started this, last year in 2014, we were sort of gearing up for a couple of big initiatives. So at the time we were applying for PCMH recognition, of course striving for level 3 if possible, and also participating in Meaningful Use, our second year of stage 1. And so for a couple of those opportunities, we definitely needed or wanted to have a patient portal available, and some of them really required it in order to make all the points that we needed. So, you know, in terms of organization planning, that's kind of what we were looking at, and we decided in the spring, around April of 2014, to sort of launch a quick patient portal pilot, just with a couple of provider champions, one family physician, and one pediatrician, to really work out some of the kinks. And it was at that time when we had heard about the CCI grant and applied. And so over the springtime is when we were really developing materials and getting some of our workflows down and working on issues. And then in July, when the grant started, that's when we were ready for sort of organization-wide spread. And so that's really where we came into the collaborative. And as Veenu mentioned, there were a number of great resources that the grant was able to provide for us. The implementation coach, Christine Crisell, she was fantastic, definitely able to provide us with resources, keeping us accountable and helping us think through a lot of issues that we were having. The peer support that we had with the other grantees was key. There were a lot of things we were able to share experiences with. Most of us actually happened to use NextGen as our EHR, and we used NextGen's website and portal products as well. So we shared a lot of the pains together, and it was great to have that support. And also, if we needed certain reports to be generated, we could share those amongst each other pretty easily. And then, of course, Shasta Community Health Center was a great host site for us. They definitely have been at the forefront of implementing the portal, and Charles Kitzman has been doing some awesome work in terms of moving ahead in portal innovation and thinking about clinical outcomes and things like that. And we also got other resources. CCI was able to bring in Judy Derman from Kaiser Permanente to share about Kaiser's experience with the portal and give us some tips on how to engage patients. So there were a lot of great resources provided by the grant. In terms of our goals, really a lot of them center around triple aim goals, sort of anything that we think about in a big initiative with our organization, we want to make sure it aligns with that. So of course we wanted to meet our required measures for MU and PCMH. We wanted to really think about and address patient barriers prior to patient or portal enrollment and usage. And I think for us, we were thinking about, we had fears that our patients wouldn't have the computer literacy or the internet access to be able to use the portal. And reading about some of the projects and clinics who have gone before us, it seemed like that a lot of their fears were not founded, that patients really did have a lot more access than they had expected. But I'll go into in our challenges, we actually found the opposite to be true in our case, where we had more of an issue than we had anticipated. Another goal we wanted to address was really engaging our own staff and having them buy into all the benefits of the portal and getting them excited about the project. We thought it would help us to improve clinic efficiency, maximize our resources, so really cut down on a lot of that back and forth phone calls and phone numbers that have been disconnected, things like that. And we know that with better communication between patients and the care team, that really would help improve patient and staff satisfaction. So this is just a quick screenshot of what our portal product looks like. As I mentioned, we're hosted through NextGen. We were able to customize our site, and this is just the home page that patients see when they log into. And we happen to call our portal My Health at Ravenswood. So some of the challenges that we faced, definitely, as I mentioned before, the computer, internet literacy, it was definitely lower than we expected. Most of our patients either reported saying that they didn't have email or didn't use email. So a lot of them, it was really just even creating an email account so they can actually create a portal account and send messages was a challenge. And then, of course, the lack of online access. Language for us, so the majority of our patients are non-English speaking, Spanish. We also have a significant Tongan population as well. And the portal product, while it has a Spanish translation, it's really just for the framework of the website. And of course, it doesn't translate the content, the patient records, the notes, the lab results, and things like that into a different language. In terms of the enrollment workflow, and this is actually where we spent the bulk of our energy and efforts, is trying to figure out where in the patient cycle could we approach them about the portal and enrolling them. And so initially we had started with thinking, well, the front desk seems like a very logical place to do this. And because the front desk is already asking patients to do a lot of forms and paperwork, we can just kind of bundle that together with the portal. But what we found was that really the paperwork just got lost in all the other things that the patients had to fill out. And it seemed to add too much time to the check-in process. Of course, increasing our lines and our wait times and definitely affecting the flow in the back office. We also found that patients were less likely to buy into the portal and go through the whole enrollment process if it was the front desk that was pitching it to them. We thought maybe because the front desk weren't the primary users of it, and maybe the patients didn't see the direct benefits of it if it didn't come from, for example, from their provider who could say, I just prescribed you this medication. I would love to hear back from you, with a message in a week or so just to see how it's going. And we thought a quick little message like that could really help sell the portal to the patient for usage. And so we wanted to try maybe utilizing our health navigators to help with this process. And so we carved out some time for them to be available for patients in case they had any issues or questions around enrollment. They did some orientations on the day that patients came in for the clinic visits, some one-on-one visits. And we also scheduled some group classes and orientations for patients to be assigned to. But we found that patients didn't really want to stick around after their appointment or come back on a separate day just to go through the enrollment process. So that didn't really work out well for us. And so with that, we kind of decided to maybe try the back office in terms of the focus of trying to enroll patients. And initially, we had started using MAs. Basically, we thought that MAs were able to engage patients better, I think, with the benefits of the portal use. They could highlight some of the direct benefits to the care team. But, of course, time became an issue for them as well. The MAs are definitely loaded with a lot of work to do, and adding the portal on top of that was a challenge. And so then we had shifted into using volunteers, clinic volunteers, really to focus on portal enrollment. And this was great. They had the most time and availability to do that. But with volunteers, it was really hard to maintain a lot of continuity with them. Most of them were not here full-time, and so just providing coverage during all business hours and for all our different departments was difficult. In terms of staff engagement, initially, when we had launched the project, there was a lot of excitement and success, I think. People were really focused and wanted to really make this a success. And we utilized a lot of competitions, had our staff, the ones who enrolled the most, get little prizes and things like that. And I think it was really great. But eventually, I think as time went on, we had a lot of other initiatives that we were putting onto our staff. And so I think people started to experience a little bit of initiative and project fatigue after a while, and there are just too many competing high priority items. And then just briefly, we were grappling with the issue of minor confidentiality and whether or not to allow access to the portal for our adolescents. And in the end, we just decided to kind of make things simpler and safer, and just to limit portal access for any patients aged between 12 and 18. So this is just our enrollment graph. As you can see in the first quarter that we were doing this, July to September of last year, we had this great upswing and slope in our patient enrollments, and then sort of just kind of flattened out as I think some of the momentum died down. We did some kind of cycle time and workflow analysis of how long it actually took to do an enrollment, and this was for our volunteers to go through the whole enrollment process, including the pitch, having the patient sign consent forms. For our product, they needed to have a token generated, a unique token that the patients would need to use then to finish and complete the enrollment process online, either at home or on site. And so that whole process took about 5 minutes, which is, I think, pretty good. And if they did just the pitch only, it took 2 minutes. But you can imagine if you added this to the front desk time, then it really starts to build. So just a few lessons learned. Change management is a perpetual process. So as I was mentioning, I think momentum can be just precious and often fleeting. And so just figuring out a way to continue, I guess, turning it from a project into really, this is a new communication method and making it part of your day-to-day operations. So I think having dedicated staff to the portal and making it part of their job description is actually pretty critical. And just to be aware of all the other competing priorities in the organization. Marketing internally is just as important as marketing externally. So we thought that, I think we did actually a pretty good job of marketing to patients, but really what excited them to sign up and actually use the portal, I think, is just a reflection of the staff's excitement. And so we had a couple of providers and MAs who really bought into the portal, and it turns out that they have the highest number or percentage of patients in their panels who are using the portal. So I think having the staff buy-in and being able to really sell the benefits of it will really encourage your patients to go through the whole portal process. And knowing your own patients, this is more, I think, something I wish we had done before is really maybe starting with a patient focus group or doing some type of demographic study beforehand, just so we kind of got a better grasp of some of the barriers that our particular patients in our community face, which may be different from some of the other populations. So with that, I'm going to hand it back to Veenu.
Great. Thank you, Justin. That was great to just hear the realities of what it takes to implement the portal, both in terms of better understanding your patients, but also how to integrate into workflow and those change management. So thank you for that. So what I want to do now is hand it off and make an introduction to Dr. Jeffrey Liang, who has been a long-term partner for CCI and a real innovator in the field. They have both served as a host site for our telephone visits initiative and have also been a great partner in making some real progress with their texting efforts. So Dr. Liang serves as the ambulatory medical director and chief of family medicine for the Riverside County Health System. And the Riverside hospital-based clinics and community-based FQHCs conduct about 240,000 visits per year and serve as medical homes for over 80,000 patients. So with that, I wanted to pass it over to Dr. Liang to tell us a little bit about their experience with how to use texting to engage patients.
Thank you, Veenu. So back in 2013, we were busy, expanding our population in anticipation of healthcare reform. We were growing our low-income health program, and we had added a lot of patients, and we were struggling, like probably many of you, with access. So we were trying to think about creative ways of addressing access, and we actually had participated with CCI with support from the Blue Shield, of California Foundation on telephone visits as one way to do that. But we also got some feedback from patients that, they weren't always able to answer their telephone at work. And we had an epiphany when we walked into our waiting room and we saw that, the vast majority of our patients were actually busy texting on their phones, and we had no way to reach them in this kind of communication mode that was a strong preference for many of them. So, we were lucky when the Texting for Better Care program came up as an opportunity, and in 2014, we partnered with the technology company Ellipsis Health to kind of work on developing a platform. And we had decided to focus on diabetic patients because Ellipsis had created a platform for type 1 diabetics before, and we thought type 2 diabetics wouldn't be a big difference. And we also decided to choose as our primary team student health coaches and nutritionists to really drive the program. We felt that many of our physicians, nurse practitioners, and physician assistants were already overwhelmed with things that they were doing and that there was limited bandwidth. And when we talked about the texting opportunity, we seemed to get the most excitement from our health coaches and nutritionists. So in July 2014, we launched our pilot platform. And we really focused, to minimize barriers with this initial pilot. We focused on established patients that we had already met in person and that our health coaches and nutritionists had a relationship with. We focused on the self-management goal aspect for diabetic patients, so really physical activity, nutrition, stress management, things like that were kind of less controversial with regard to HIPAA and compliance. We did spend many months getting an agreement between ourselves and our technology company partner, sort of moving things through our security office, and we did make sure that we had an IT member as part of our primary implementation team. So in this initial workflow with signing up patients, in general what we did is we actually signed people up in person, and so we know this might be different than many texting programs. So, if a health coach or nutritionist just had a visit with a patient and they had set some self-management goals, then the health coach might end the visit by saying, we've got this new program. It allows you to text message with myself and the rest of the team, and that way we can keep in touch with you in between visits. Are you interested? And if the patient was interested, we had them sign a written consent. Then we kind of followed that up with a text message confirmation, and we built a profile for them within this platform. And this allowed the patient and the care team to send text messages in a bi-directional way. So it wasn't just us sending text messages to them or them sending text messages to us, but kind of both ways. And we found, that patients were very excited about this, and we didn't anticipate it, but the staff were equally excited. Patients, prior to that didn't have a reliable and sort of fast, asynchronous way of communicating with our care teams. And so, this sort of introduced one way that patients could access their team almost any time. We tried to align the technology with the existing workflow, and here you can just see some examples of incoming text messages from an administrator view. And again, in most of these cases, patients may have had a conversation in person with their health coach or maybe by telephone. They may have set some initial goals, and then what you often see is the health coach or the nutritionist following up with the patient, asking them, how they're doing, and then these are actually messages from patients just over a 20 to 25-minute period. And you can see that many of them are Spanish-speaking. We tried to make sure that this program really aligned with patient needs. So patients sort of drive the topics of conversation. They set their own self-management goals. And, we found that this really provided a rapid asynchronous communication method. And we could find out very quickly from patients, if they might have just received a glucometer, or if their glucometer just broke, or that if they were starting to have challenges. And in a normal situation, we might not have realized that until 2 or 3 months later when they came in person. So we found this to be a real benefit, and health coaches and nutritionists could also communicate information with the rest of the team. And so sometimes the rest of the team would reach out to patients. So here is just a screenshot of one kind of component of the summary view that we have for each patient. And again, our focus was on self-management goals. So you can see these are just some examples of self-management goals. We have some color, visualization, so we can see how well patients are doing. And we kind of measure how patients are doing based on their text messaging and their responses, and we put them in a green, yellow, or red zone. And patients can actually access the same view through a patient portal. And then you can also see a screenshot of some of the clinical measures that we follow, including hemoglobin A1C for blood sugar control, blood pressure, cholesterol, weight for healthy weight management. And we really found that with this program, that small, frequent nudges to influence behavioral change seem to be much more effective than our traditional infrequent kind of sledgehammer in-person visits, where we would try to accomplish too much within a single visit because we never knew when we would see the patient again. In this case, with the frequent text messaging, we could just have a very brief conversation with the patient. We could do it every other day, and that has really helped us move our clinical measures in a way that was otherwise very difficult. So this is actually a sample of our pilot patients who had at least 2 post-intervention hemoglobin A1Cs. And from this graph, what you really see is all the blue is kind of improvements in A1C, and the reds are kind of worsening of A1C. And you can see in general, our patients kind of improved on average by an A1C of 1.8, which again is really remarkable in our safety net system, even with all of the turnover in patients, the many new patients that we get, and the common challenges that most public safety net systems have in terms of following up and reaching patients. So this reduction in A1C was really quite striking for us, as well as the positive feedback that we received from patients. So, just in looking at kind of the program that we started in July of 2014, and it's now been approximately a year, we've found the text messaging to just be a tremendous gift and kind of catalyzer. We've seen better clinical outcomes. We've seen greatly improved communication. From a technical standpoint, we're able to reach or touch more patients in the same amount of time in a meaningful and effective manner, kind of in between in-person visits. We've seen improved patient engagement, and patients are just so happy that they can use this method of communication. We think this is sort of more patient-centered than many of the traditional approaches that we've had. It aligns with kind of a value-based approach to care. We've seen kind of improved stickiness between patients and their care teams, and it helps us with moving care out of the hospital and out of the clinic, which is in line with that triple aim. The biggest challenge for us is there's no direct reimbursement for text messaging. Although we found that with the improved clinical measures and the improved P for P that we can pay for performance money that we can draw down from the improved clinical measures, this appears to cover the cost of the program. And so kind of going forward, we're now in the process of expanding beyond diabetes. We're expanding into other healthcare team members besides health coaches and nutritionists. The challenges that we've seen with that are kind of bandwidth and buy-in from different groups. So although we've had many different groups that have expressed interest in participating, we tend to go with the groups that are most enthusiastic and excited. So we recently launched a new patient portal. We revamped the website. We have a survey module coming out. And we're just very excited about having this as kind of a supplemental tool because text messaging is not necessarily a function that is kind of encompassed within most legacy electronic health record vendors. So we've been grateful to be a part of the program, and thank you for listening to a little bit of our presentation. Thank you.
Thank you. Thank you, Veenu, Dr. Wu, and Dr. Liang for those insights and for taking the time to share your learnings with all of us today. So we'll now open things up for questions. And as a reminder, if you would like to ask a question, please do so by typing it into the question window on your screen. Unless specified, we will distribute each question to the most appropriate speaker to answer verbally. So we'll start with a question for Veenu, and perhaps Dr. Liang and Dr. Wu can weigh in as well. Please share your thoughts regarding the idea of patients and providers being able to access electronic medical records through mobile devices rather than using them only for texting.
So I can start, and then I'd love to hear both from Justin and Jeffrey about this. So I think the reality of how the world works now is, and I'm sure most of us use our phones for just about everything. So I think we have to get to a place where we are making available, whether it be the EMR or a way to be able to communicate with our own care teams or a way to communicate with our patients. This needs to be a viable mode of communication. I think we're using mobile phones for just about everything else in our lives, so I don't see this as being much different. I'm not sure. Obviously, there's issues of security that need to be worked through, and also a matter of making sure everyone has the devices to be able to do that. But from my perspective, I see that this is only going to become a more viable way of communication. So I'll let Jeff or Justin weigh in as well.
Yeah, this is Justin. So I definitely agree, Veenu. I think what we found, if our patients did have internet access, they were probably more likely to have it through their phone than through like a desktop machine at home. So I think that's probably a better way to interact with them. The challenge we found is just with our particular product and vendor, there's not a great app or mobile solution right now. There's something that works, but I think it can definitely be developed a lot better. And so we're probably a little bit a ways from making a product that I think people really flock to. But I think it's definitely a key area that we need to really look at.
So this is Jeff, and I agree with both Veenu and Justin. I think as long as you have software or applications that are sort of mobile device agnostic, I think it does make sense to move towards that direction long term.
Great, thank you. So we've got another question coming up for Veenu. Are all your mentor sites primary care facilities? And kind of a second question, do you find that if patients require specialized care, they are more or less engaged?
So for our initiative, all of our mentor sites have been primary care facilities. In most of our programs, we're really focusing on making changes at an ambulatory care, primary care level. So we try to ensure that our host sites are most similar, like those who are participating in the programs. In terms of the question around whether patients requiring specialized care are more or less engaged, I don't know that it's necessarily a factor of needing specialty care or primary care. I think the engagement factors are much more complex and you know, are a factor of people having kind of the tools, the communication, the information, the you know, incentives, motivation to do that. So from what we found, I don't know that that's a unique factor in engagement levels.
Okay, thank you. So Dr. Wu, we've got a question. In your portion of the presentation, you mentioned portal access for minors ages 12 to 18. Could you please clarify how you handle parental access for that group?
Sure, yeah. So we thought it was a tricky situation with confidentiality and just you know, for kids younger than that, parents are the caretakers are the main managers of their portal account. So once they get to age 12, we run a report where we see patients who are going to be turning 12 in the following month, and then we just expire their portal account. So we just don't allow access for either the patient or for their parents at that time. And then once they turn 18, they can again reapply and reactivate their accounts.
Okay, thank you. One more question for Veenu. Could you please address the ongoing challenges of the digital divide on the adoption of patient portals and texting programs?
Sure. So over time, clearly the digital divide when it comes to text-based phones is decreasing, as the data shows through the Langer studies and other studies done by the Pew Internet Group. You know, 90% of people have text-based phones. I think the challenge with the digital divide is as new technologies come into play. So for example, if everything out there is designed for a smartphone, we know that smartphone penetration isn't as high as text-based interventions. And so if a lot of the entrepreneurial solutions and products we're using are smartphone-based, then there's going to continue to be a digital divide. If in the future there's a new instrument or tool that comes out, usually as these products and solutions become more costly and are continuing to evolve, the more we emphasize these cutting-edge tools, I think there will be a digital divide. That said, I think a lot has been done now through texting and being able to access internet through phones. So I think that's a vast improvement, but I think, you know, in looking at the entrepreneurial community and looking at the new solutions that are coming out, I think we need to constantly be thinking about, do people have access, do people have tools, and making sure we don't leave out a significant portion of the population, and make sure we're designing solutions. So for example, with the acknowledgement that a lot of people do have text-based phones, how do we make sure that that at least is a way to communicate? So I think obviously there's more to be done around improving internet access. As Justin pointed out, not everyone even had email addresses. So I think when we think about our underserved populations that we're working with, there's definitely going to be different approaches that we need to try to enroll people, make sure they have email, understand how they are going to access internet, whether it be from their own home or through family members. So I think we're definitely not there yet, but I'm hopeful that that divide will decrease over time.
Thanks, Veenu. Our next question is for Dr. Liang, and maybe Veenu, if you have anything to add at the end, you can also jump in. The question is, does texting add more burden to the physicians, and how do you actually send the text message to the patients? Is it, for example, through a centralized portal?
So that's a great question. So regarding the first piece, we intentionally started this program with our health coaches and nutritionists because we did not want to add to the burden of our physicians. So in our case, it did not change the workflow or the workload for our physicians. And then when we send out text messages, we do use a web-based platform. So people are not using their own smartphones at work and sending messages to patients, but they're actually using a web-based portal. And all incoming text messages from patients kind of come in centrally into that web-based portal.
And I'll just add that in our program, the Texting for Better Care program, I think how Jeff described it being through a centralized portal is pretty much how most people are doing it. It's not one provider texting one patient at a time, but there's really kind of an automated system of how you send out messages, how do you manage it, and in many ways a lot of the workflow burden isn't really necessarily on the physician, but other parts of the care team.
Great, thank you. And Veenu, for entities that contract with private providers, such as specialists who are not eligible for grants, what advice might you have to help them implement these kinds of technologies?
Yeah. I mean, I think we're to a point, like in many ways, a lot of the grants were really to help get folks started and a little bit of bandwidth, but really, especially for some of the texting programs, the costs of implementing texting have come down so much. And as Jeff said, they're able to make a case for sustaining, implementing, as well as a lot of the appointment reminders. People are even under a fee-for-service environment able to justify the cost because they are so low. There are a number of great toolkits on our website which share many of the tools that are coming out of the program, so consent forms, things like that are out there. We're also happy to connect people to others like them who are implementing if that's helpful. But I think with the portal work and the meaningful use dollars coming in, I think there's definitely some incentives to help provide some of the funding needed for the technology. And honestly, I think with the texting programs, the costs have come down so much. There's also products that are rolled into or integrated in with EMR systems, so it becomes an offering within. I think we're to a point now that the pure grant dollars aren't as helpful, and there are now getting to be more and more tools out there. So I would encourage folks to look at those as well.
Thank you, Veenu. So we're going to take two more questions. This one is for Dr. Wu, and perhaps Dr. Liang can also weigh in. Dr. Wu, you mentioned incentivizing clinic staff to enroll patients in the portal. Did you also consider incentivizing patients?
That's a great question. We didn't directly consider it. I think we were hoping that the incentive enough would be that they could, have more efficient and direct communication with their provider or care team, that they'd be able to, access their records when they need to and look up their lab results and things like that. I don't think for us, I think it was more the barriers of the email and the access more so than the patients who, it's not like the ones who did have the ability to enroll themselves. Most of them, I think, did want the access and desired it just based on the clinical benefits. But it's something definitely to think about.
Great. And Dr. Liang, did you want to weigh in on that at all?
Sure. So we did not incentivize our patients to sign up. We really offered the text messaging as just one more way that patients could communicate with us, and we asked kind of patients to choose their preference.
Okay, great. And so this last one's for any or all of you. Have you been able to assess the benefits of using patient portals and text messaging, both for the patients and also for the staff?
This is Justin. I think this is definitely something we would love to study more in terms of, I think, workflow efficiencies and maybe how, if it cuts down on our telephone call volume, things like that. We haven't really examined that yet, but definitely it's something we're thinking about. And just, I think, anecdotally, it definitely helps, but having some hard data always helps.
So this is Jeff. The only area where we've been able to do a good assessment is on the clinical outcomes. So we did see an improvement in hemoglobin A1C measures for our diabetic patients participating in the program. The next step that we're working on is actually surveying our healthcare team members who've been participating. And up till now, most of the feedback we've had has been anecdotal. So we're trying to get some formal survey data to see if that, in fact, is true that the program has been beneficial in our healthcare team members' eyes.
And this is Veenu. I'll just add from our programs, because they're so early in, we don't have a lot of hard outcomes data on texting and portals, although I know some of these studies have been done for various use cases, and with the portal I know Kaiser's done some work around that. However, what we have been able to see is there's definitely improvements in patient experience. There's definitely, for those doing appointment reminders, definitely improvements in access to appointments and care. I think many of the staff that have been involved sort of across programs, once the workflows are more standardized, there's some benefits in streamlining staff workflows, saving times, especially with having to do a lot of phone follow-ups and things like that. And I think in general, given the way the world's been moving to incorporating more technology, I think by taking these steps in programs like this, it's also sort of enhancing organizational capacity to engage in technology programs for the long run. So those are some of the things we've been seeing, but I think we're still early in to have a lot of hard data on clinical outcomes from these projects specifically.
Thank you all. So unfortunately, we are out of time for questions at the moment. Fear not, we will be getting to the rest of your questions. More on that in just a moment. I did want to make a final note for any health center professionals out there. The Clinic Leadership Institute is now accepting applications for its Emerging Leaders program, which is an 18-month leadership development opportunity for professionals working in California's community health centers. So I encourage you all to share or apply by visiting UCSF Center for the Health Professions website at futurehealth.ucsf.edu. Thank you all for joining us and for your interest in advancing patient engagement in the safety net. A recording and slides from today's presentation, as well as answers to any questions that we weren't able to get to, and a host of other resources related to this work, will be available on Blue Shield of California's website, blueshieldcafoundation.org. And a follow-up email with details on how to access this information will be sent to all of our participants. Thank you again, and until next time.